All righty, we're at the top of the hour here, the noon hour. Good afternoon. Thank you for coming, everybody. Mark Rolfe, Executive Director of Communication Marketing, for those of you who don't already know. So real quick, I'm going to introduce our esteemed speaker for today, but a reminder for those of you who may not have come, these are UMMC 101 sessions. These are more basic level type of information about a topic relative to operating an academic medical center. So today, one of the big parts of it is money. And I can see there's a lot of business role people here who are going to find this helpful. Won't go into the real finite details about the topic, but definitely going to give us an overview and help out. So I want to introduce Jennifer Sinclair. She's been our CFO since
6 months.
6 months. 6 months in there now. And she has a lot of experience coming from health systems, accounting firms, and also some little insurance company that we won't mention. Which is, I'm sure the finances of that won't be discussed today, which is fine. Jennifer, look forward to your talk. Thank you, everybody.
Well, thank you. I'm double mic, so I hope everybody can hear. Okay, so I have been here 6 months, started in April, so happy to be here and have learned a lot in the first 6 months. And so just quickly about me, I am from Mississippi. I was born and raised in Morton. Majored in accounting at Mississippi State and started my career at Ernst & Young, where I kind of got into healthcare. I really spent the bulk of my career, about 18 years at St. Dominic's. Is it okay?
Feedback. Go ahead, keep talking.
At St. Dominic's, where I did controller, finance. I was CFO there for many years, and even did as the chief operating officer for several years, and so got exposure on the operational side of the business. I moved then to Toledo, Ohio as a regional CFO, and came back after a period of time there and worked at Blue Cross for 4 years. And so that did give me a different perspective. Most of my career has been on the provider side, and so having payer experience for 4 years was quite different. And we'll talk a little bit about their business model today and how it impacts us. Are we good? And then back here, and I'm thrilled to be back on the provider side. It's where my heart is and my love for healthcare, so I'm glad to be here. So from an agenda perspective, I was going to cover just current state of healthcare finances broadly, and then talk a little bit about future state, what payers are looking at and what it means to us. And then talk a little bit about the difference between an academic medical center and community providers. And then talk more specifically around UMC, what our finances look like, what our finance team looks like, and then the budget going into 2025. But anytime you have questions, please stop me. I'm happy to, and then we'll have a section at the end to ask questions too. And so I think these are probably slides, at least the Ochsner one, that you guys have seen. And so if you followed the news at all for years, but specifically this year, most hospitals across the country and in Mississippi and surrounding are continuing to face significant financial pressures. COVID made those things worse, but during COVID, there were some federal dollars that helped offset the increase in costs that we saw. As those have gone away, most or some of the cost increases have not. And so hospitals are struggling specifically with inflation around our costs for supplies and the cost for staffing, finding enough staffing, the rates that we're paying to staffing agencies so that we can staff and take care of the patients that come to us. And so it is very common to see layoffs where people are trying to get more and more efficient. At the same time, we're continuing to be pressed from our payers. And so, the business models on the payer perspective is they set premiums that are paid by employers, and premiums are set based on what their claims are. And so the payer perspective is that they're trying to react to employers who can't afford to pay more in claims cost. And so they're wanting to keep claims payments down, and to do that, they want to pay healthcare providers less or minimize. And so you can do it through rates, what you pay for services, or you can do it through utilization. And so we're going to talk some about that today, but that's how you control the cost. And And then it complicates even more as you factor in new technology and the cost of drugs, and all those things continue to escalate. And so we all find ourselves in this business model trying to balance it, and it gets harder and harder every year. And I know all of you are feeling that, but that's the best I can do to explain the current state, is that it continues to get tighter. And so we're going to have to, as an industry, continue to look at ways to help respond to that and manage things in a different way. And so we're going to talk a little bit around future state. This slide I particularly like. I found it, but it looks like chaos, and which I know it feels like to most of us every day. But there are a lot of things changing that has different impacts. And so you'll just see, I won't go through obviously all of this, but the need to be more inclusive. And so we read about results of how different groups are not cared for in a similar way. And so we've got to figure out ways to be more inclusive and respond to individual needs that are changing. Then the whole digital impact to the business is big. And so all that to say, lots of changes in our place, lots of new entrants into the markets. And so other people and other businesses are trying to figure out ways to impact healthcare. So you'll see Walmart getting into the space or Amazon getting into the space, all with the same intent, is to figure out ways to make it more sustainable long term. So then I did some of these to get into some specifics around current state versus future state and payment models specifically when we talk just finance. And so today, or in the last several years, we would say that care revolves around tertiary facilities or academic medical centers and the services we provide within our four walls. Future state is moving that into more community-based providers and looking at the entire continuum of care. And that's a struggle for us today. You know, our resources are limited in the acute space. We've got to have partners in the continuum to move patients through so they're out of the acute care in a continuum, but partnering us so that we can make sure that they're still cared for appropriately and don't come back to us. And so more and more pressure around that continuum. The next item was siloed medical centers, where it's the spoken model, where really, again, similar to the first bullet point, but where patients are coming here for services and just come here and we're done, versus an integrated where we're partnering with providers, post-acute providers, rehabs, SNFs, all those other healthcare providers that are also touching that same patient when they're not with us just in the acute care facility. So it's going to be more and more important for us to be able to meet the needs of the patients and our payers, that we're working together with partners outside the four walls of the academic medical center. And then the next one I know you guys have talked about, and we have a strategy moving forward, but moving surgeries out of the main campus into a surgery center setting. And there's a couple of reasons for that. It's generally cheaper to the payer. And so payers for years now have moved surgeries out of an academic, out of the hospital, and said these can be done in a surgery center, and we pay less for it. It's also generally more convenient to a patient to drive up to a smaller facility off campus rather than navigating the big hospital. And so we're working on that strategy, but that has been playing out. And I'll tell you, recently, probably 5-7 years ago, Blue Cross Mississippi came up with a strategy where orthopedic procedures were being shifted, were total joints and some spine procedures in surgery centers. And today, that's the only place they can be done, in surgery centers. And so there's going to be a more and more drive from payers to continue to move those surgeries out into that lower cost setting. And then the next one would be most care providing in hospital walls. And so I thought during COVID, we saw the origination of hospital at home concept. And so there are providers across the country that are trying that. I would say some with more success than others, but can we move and provide acute care services in the patient's home rather than in a facility? And so we'll see more and more of that, especially as the remote technology is there, where you can do some monitoring of the patients in their homes. And then focus on care, prevention. rather than just focusing on the care, focusing on prevention and prediction. You guys probably all know more about the prediction than me, but prevention for sure is important. And lots of payers have looked, and we do some of this, but looked at strategies around how do we prevent certain things. And certain things can, some things can't, but at Blue Cross anyway, we had a model of managing patient lives. And so we all know if patients can come to you more often and have their wellness screening, have preventative care, then it prevents longer term illnesses that may occur had they not had that care. So that will be more and more important, and important that we can show that we can do that. Then if we talk future state of just payment systems. So today, 99%, I should say, probably closer to 100%, honestly, if you look at the numbers, of our business is paid fee for service. And what that means is the patient comes to us, we provide a service, the provider sees it, we do a procedure or whatever, we bill the provider, and we're paid for what we did. Insurers or payers are trying to move towards payment for quality, payment for outcomes. And they've done that in some settings. Generally, in Mississippi, I've seen a lot of upside only, meaning they'll only pay us for an improvement. But some parts of the country, there's downside, where there are penalties associated with outcomes of the patients that you're taking care of. Another one would be bundled services around episodes. And so I mentioned earlier that Blue Cross was moving some total joints and spines into the ambulatory setting. Well, they started many years ago doing that in a bundled payment methodology. So if you think about today how billing works, normally a patient would get a bill from the hospital, and then a bill from the anesthesiologist, a bill from the surgeon, a bill for physical therapy, a bill from DME. A bundled is where they pay one flat rate for all of those services, and somebody's in charge of making sure that they manage what all of those services are. And so that's happening. It's happening with Blue Cross with a lot of those providers today. I'm not aware that we've done any of that yet, but it's something that is coming. And it just makes us responsible for managing that continuum of care. This generally works on an episode like that one surgery, not something that's ongoing long term. And then payment for a population, such as an accountable care organization or an ACO. And there has been a lot of penetration of this in the market locally. Managing lives, a payment to provide primary care services that really take care of people, do their wellness, keep them out of the hospital, or when they need to the hospital, make sure they're going in the most cost-effective way. So rather than going to the emergency room for care, going back to your primary care doctor. And there are lots of organizations, particularly in the Medicare Advantage space, that have done some ACOs, and they're sharing savings back with providers that are able to do that. And there's a lot of groups in our local market that have been very successful doing this. We have one contract where we're doing it and have been very successful with on the children's side, where we're managing some chronic kids on they're paying us a per member per month, and so a monthly fee, and we've been very effective and have generated positive savings for 2 years in a row. And so it's stuff we can do. We just got to get ourselves organized around and be able to contract with payers and show them how successful we can be. But we'll see more and more of this coming in the future years. And then just sustainability here. Again, today, many of the managed care plans have done lots of these early attempts at value-based, and so they've done the upside only for quality. They've done the per member per month for managing lives in the primary care space, or some of the ACOs, and we'll see more and more of that. More emphasis on prevention. Precision medicine, I need to learn more about that. I do know there's lots and lots of new technology and tests out that help predict whether certain treatments are going to benefit patients. Today, many of those things are not reimbursed, but as they get better and we can prove, or they can prove the benefits of it, I think we'll see more and more of that. The next slide is, I was just going to talk a minute on how is an academic medical center different than a normal or traditional community-based provider. Most of my experience has been on the community-based side, and so I'm learning the academic piece. It's been very interesting to me. But these are just some key bullet points. Academic medical centers generally are involved in graduate medical education with federally funded research. You don't see as much research or academics in traditional community-based hospitals, generally just because you need that additional funding to be able to make the finances of that work. And so actually I've enjoyed seeing grants come in. It's like new dollars I've never had before, so that's kind of been fun. Our state appropriations, that's been different too. We have a triple mission here, so where we're focused on clinical care, education, and research. Again, generally speaking, you see community-based providers focused on the clinical side, and so they're running their hospitals, running their physician practices, and focusing on just the clinical section. The medical school, and I'd say the big one is a more complex governance structure. Management team, the whole finance structure. It has been different here. When I first came, it took me a minute to figure out what is the difference between a chair and a dean and an associate. I mean, there's a lot of titles and differences that it's taken a minute to figure out. That's different than what you see in a traditional community-based, and it requires that we work together different. And so there are nuances that, not bad or good, it's just different than a lot of community-based providers. And then typically, because of the work that we do, the payer mix is generally different, and payer mix is who's paying the bills, and generally you see more uninsured, usually more Medicaid in an academic medical center than you do community-based providers. The other thing I would add specific to us is in the state of Mississippi, we're governed by the Institution of Higher Learning, IHL. And so IHL are the 8 colleges plus us. And I think you all know, but we report up through Ole Miss. And so that's a nuance that's a little different. And what it means practically, when our financials are done at the end of the year and audited, they're all combined. And so we become part of the broader IHL. And so it matters what we do because our financial performance impacts all of those colleges in the IHL, if that makes sense. And so it does add complexities to what we do each day. We're going to talk about that some, but it was very different than just being managed by a sole community board that helps you make you can make financial decisions a little quicker sometimes in that setting. Okay? Then I'm going to get some specifics into UMC's financial performance. So this is our balance sheet. So has anybody ever gone to the bank to borrow money, and one of the first things they're going to ask you to do is a balance sheet to list all your assets and liabilities. And so the purpose of this is to see what is the value of your net worth. And so they're going to ask you to list your cash, your jewelry, your house, your cars, but then they're going to want to know, okay, how much do you owe on all those things? And so the difference between your assets and what you owe is the value, your personal value of what if that makes sense. And so it's no different here. So this is a balance sheet for us at UMC. And so I know it's going to be hard to see, and I'm not going to go through the details. I'm going to just point out, we look each month at total current assets, and that really is our cash and accounts receivable. And I'm going to show you slides specifically on that. And then the other assets get into the building here, the equipment. And so you'll see that 900 billion number, and 900 million number in total assets. And then, so our assets are here, and then the liabilities, the big things for us are bonds. And when I mentioned earlier, we're part of the IHL, and so when we need to borrow money to build buildings here, we have to go through the IHL to get approval. And so the debt that we carry impacts the broader IHL. And then the other big thing for us is the pension liability. And again, that's a number that we get back from the state every year as they do the math. And so it's our piece of the broader pension for the whole state. And so if you say, what is it that we do to manage our balance sheet? What I would really tell you is this is where we focus. We like to look at cash and accounts receivable. So the first graph here shows in orange, you see the moving target, that was our cash days for 2023 by month, and then the blue is this year. And then I've got an IHL target listed there of 90 days. And so I keep mentioning that we're part of IHL, but with that, IHL has to be responsible for all the bonds and the debt that we owe as an organization or as a whole entity. And so they set targets for each of the colleges and us of what are the financial metrics that we need to hit to be a healthy organization. And the 90 days of cash is the target that they've given us. And so you'll see orange, how we did last year. Blue is how we're doing this fiscal year. And so our fiscal year starts July 1st. We produce financial statements every month to show what that looks like. And you'll see here, we're running in the mid-80s, 81 at the end there in September, and October looks about the same. We do have some volatility as payments come into us, and so there are some payments that we will get in July, and so that number will go back up, or not July, I'm sorry, that in December, that number will go back up some. And so we are budgeted to end right at 90 days. And what that means is the days cash on hand is how many days of our expenses could we continue to pay if no more money came into us. And so you'll see about 90 days is what we could pay, assuming nobody paid us at all. Does that make sense? And then, so when you're asking for things in your budget or you're wanting to spend money and you say, oh, and you hear we got to manage cash, that's why we have to manage cash, because we're right on the line right there of being at that 90 days, which is IHL measurement of how well we're doing. And then on the flip side, our cash has a lot to do with how much money we make, but also accounts receivable. So accounts receivable is the number from the patient care services that we provide, and you could even say in the academic space, but the big number comes on the patient care side. And so it's how long does it take us to collect the revenue or the money that's due back to us for the services that we provide. And so you'll see here, we're at 42 days right now. Our target is a little higher than that, 44. So really we're doing pretty well in collecting accounts receivable as of now. Does that make sense? So the 42 days represent how long it takes us to collect all the money that's due to us. And we monitor this. We monitor AR daily. We monitor cash monthly, but we report this to the AHL board every month as well when we meet with them. And so I would say these are the two very important metrics off the balance sheet that we manage. Anybody have questions on those? Okay, so then if you think through your balance sheet, big picture, what your assets and liabilities, the next thing you think about, if you think about you personally, is your salary and your monthly expenses. And so how much money do you make every week, every 2 weeks, and then what are your expenses? And we all know that you need to make more than you spend or things don't work out right. You dip into your balance sheet or your savings accounts. And so no different here. This is an income statement that just represents how we're doing each month, producing revenue and spending it with a bottom line. And so it's busy, and I'm going to show you some better slides on this one too. But really, to the left is the current month of October. To the right, this section is for the period July 1 through October 31st. And so this is a real reflection of how we're doing for the first 4 months of this fiscal year. So at the very top, and I'm going to show you a graph that has more detail, but we have our total revenues. Then the middle section is the total expenses, and then we come up with an EBITDA. You may hear that word, but EBITDA is earnings before depreciation, interest, and investment income. And then we have a true bottom line. And so we're budgeted, if you look over here, to make a 2% margin, and we're running so far at a negative 0.3% margin. And so we're running a little off, about almost $10 million off here year to date for the first 4 months. There's a lot that will happen before the end of the fiscal year. I'm not too concerned about that. I think we'll be able to make it up. But what's, I think, helpful to see prior year. So you'll see the EBITDA this year of 19.2 million, we were at 6.5 last year. And so while we're running behind budget, we are running ahead of where we were same time prior year. So that's the good news. Sorry, it took me a minute to find my numbers there to make sure I'm looking at them right. Does anybody want to guess, if you're looking at our revenue, how much comes from patient care services? I'm going to go here and show you. And so then this, I think, helps put in perspective. I know those numbers were hard to see. So if you look at our patient care revenue, this is the total of our revenues. 75% of our revenues come from patient care services. And so that's what we're billing in the hospitals and on the professional side. And then if you look, state appropriations, that's 194 million a year. And then the other category makes up a lot of stuff. And so if you look at the details of this, though, patient care services, and we put just a few bullet points here, because there's a lot that goes into just what that number is. Gross versus net. And so what we bill is not what we collect. And that's not unusual to us. That's how the healthcare world works. And so we'll have a standard rate, and we'll have a standard rate, and then we're paid based on a negotiated rate from our payers. And then case mix index is another term that I'm just giving you some definitions here. So as you talk about net patient revenue and how we manage it, case mix is a reflection of the severity of the cases that we're seeing. So the case mix at UMC is much higher than the case mix I'm accustomed to next door at St. Dominic's, because we're taking care of more acute patients here. It also means that we're paid more per patient. And so that's what you'll hear the word case mix. And so when we look at that month to month, it really should give us an indication of what your payments are going to do. Because if your case mix goes up, in theory, you should also be paid more for that care. Payer contracts, I know y'all have heard that word a lot. Lots of drama around that over the years. And it continues to be a pain point. And so what our payers are wanting from us is ways to help them, partner with them to manage the cost. And so we're going to need to be able to do that more and more. And so, we're going to always take care of the acute, but what are the things we could do proactively to help manage those expenses? And so we'll need to get into that more and more over the years. And then a big issue for us has been denials management. It's not easy. It's not as simple as the patient comes in, we file the insurance and get paid. Y'all know it's not quite that simple. It's much more complex. And so there's, things that payers won't pay for. There's administrative burdens that they ask us to do, prior approvals. Let them know that patients are here, let them know the patients continue to be here. And so they'll ask you to tell every day they're here and if they stay. And any of those things we do or don't do right, either because we just didn't do it or we didn't know which insurance the patient had, all those things make it very complicated to get paid for that 75% of our revenue. And I will mention while we're talking about that, we are working on an engagement with an outside consulting company now that just kicked off to kind of help us look at the revenue cycle and what are the things that we could do more consistently and more thoroughly to make sure we're paid properly for all of that care. So you'll hear more and more about that, I'm sure, as we continue to go. And then that's the more complicated area, but we do have lots of nuances in that academic space too around revenue cycle. And that falls under the other 15%. So in that is grants and tuition. And so the tuition there, while the number's smaller, it's still what you would expect. And so there's processes to generate what the tuition should be for the services. It's a little different in this space though, because we have a little more control. Generally, students want to pay because they can't graduate if they don't, or they can't finish their degree. And so they're more interested in paying us than sometimes we find on the patient care side. And then other things that fall in there are fundraising, and we are beneficiaries of fundraising activities that are very helpful to us and help us to do things that we couldn't do ordinarily. And then miscellaneous stuff around bookstore, cafeteria, those kind of things. And then the state appropriations, that's the number each year that we work with our state legislators to help fund, really help us with the academic and the schools and the grants or I shouldn't say grants, but the other pieces of our business. Now, expense side, I don't think this will surprise you either. So if we look on operating expenses, you'll see labor and benefits are 64% of our total budget. And so when we talk about needing to make tweaks, needing to manage our budgets, a lot of times we're going to look at staffing, and that's why. It's 64% of our total spend. And so it's very important that we match and align staffing to volumes. If that makes sense, because if we don't have the revenues coming in, we can't afford to pay for the staffing. And then supplies is the other very big category at 20%, and that generally goes with volume. So the very expensive things there are going to be the implants, devices, and drugs on the hospital side. We do a lot of things to try to manage those costs. But it's 20%. So 84% of our total budget are spent on those two lines. Any questions?
Yeah, what does it look like if you break our expenses down into the same categories you had on the previous slide? The patient care, the state appropriations, and the others?
That's a good question. If we broke expenses down here, I got to think about that for a minute. We spend all the state appropriations, really, there's some specific nuances of that and y'all got to help me here. Cancer Center gets a direct one. Most of it goes to the academic piece. I don't have anything with me that shows the distinction between the two, but we do have those. And we're working hard to make sure that we want to produce financials between the three missions, and there's so much overlap sometimes between them, specifically in segregating out faculty's efforts towards academics versus clinical. And so we have those numbers, but I would say work can be done and to make that better. I didn't really answer your question. Yeah. We're working on it. We have some data, we're working on it. Does that help? Okay. This is a graph that we do each month and present to the IHL for those people that are visual learners. And so you'll see we took budgeted, in this case EBITDA, and we do that because that's really the operations. It's excluding interest and depreciation. Depreciation is when we buy a piece of equipment, we like to spread that equipment over how long it's useful. So if I have a car is generally going to last, let's say, 5 years, and so I would take that cost of the car and spread it over 5 years. And so we factor that out here. So we take that and then we say, what's the difference between budget and actual? And then we do graphs. And so just to highlight. And so you'll see patient care revenue, actually we're $7.4 million over budget for the first 4 months. But then you see the big red, and that tells you where we've missed. And so consistent with what we've seen for a couple of years now, I would say agency labor and in that staffing is where we're continuing to spend more than we budgeted. So, any questions on this one? Yes?
So when it says agency labor, that's like not UMC staff, that's like staff that's from outside agencies that we're bringing in to fill in the gap.
That's right.
Okay.
Mm-hmm. And now, why do we need to make a positive net income? And so I showed you that number over here. We budgeted $35 million in net income. And some people would say, wow, that's big. Some people would say, wow, that's too low, it's only 2%. But why do you think we need a positive net income? And I'll tell you, if you think about how net income comes, it's revenues minus expenses. And so it's creating cash that's available to be spent. And so if I had money, I spent my expenses and there's a balance left over, there's money to be spent. And what we do as a state agency is invest all of our cash back into capital investments. And so when you need another car or a new building or equipment, we've got to make a positive net income to be able to generate the cash so that we can make those investments. Does that make sense to everybody? So that's the importance of it. That plus, I should add, it's important for this purpose. It's also important for the broader IHL and for the people that we owe money to. And so nobody would let us borrow money through bonds if we couldn't show that we're going to be able to make money and pay them back. And so it's important that we have a positive net income to be able to show a healthy financial performance and then also do this. And then one of the questions that we get asked pretty routinely is, how do you set what that number needs to be? And that you could get a lot of different answers to that, but I'd say from a very high level, we like to benchmark and say, how does our performance look compared to other people that do what we do? And how do we compare with them? And I would tell you we're doing pretty well. I mean, lots, particularly on the clinical side, lots of hospitals are losing a lot of money right now. It's a very tough market in healthcare, and so we like to know what's happening in the market when we set what our budget's going to be. And then IHL's financial position. And so we do have those benchmarks, and so they give us a handful. I mentioned days cash on hand, but they also like to look at how healthy our balance sheet is, and so how much debt are we carrying, and there are benchmarks around what IHL can allow us to do. And so we have to factor those in as we're planning each year, planning our net income and what our revenues and expenses are, but then also planning how we're going to spend our cash and how much can we invest back in capital. And so we have to factor all that in. And then I put targets related to those things. So profitability, they give us targets for that, debt position, liquidity, meaning those days cash on hand, we want to stay at 90 days, and then total capital spending. And so we like to factor these in, what makes us a healthy organization, and how can we get better. And so we've tried to, if you look at what we budgeted for 24, it was an improvement over 23, and we'll want to continue in that trajectory for 25. Any questions on this?
Who are our peer organizations? Like, who would be considered a peer organization?
Really, we need to look at other academic medical centers because we're much different. The payer mix and what we're doing is much different than most other providers in the state. Okay, and then I know a lot of you have heard we did do some restructuring in the finance team since I've been here, and so this is certainly not everybody, but this is the buckets that we put the finance team in. And so Joyce Turnage, she did move down to the front row here. She's Associate CFO for Financial Reporting and Accounting. So Joyce will do all things accounting, so accounts payable, payroll, asset management they're responsible for, but also doing the financial statements, the hospital piece, the whole set of financial statements, balance sheet reconciliations, all those things will fall under Joyce. And so we're happy to have Joyce on the team. Sam Yeager, also new to the organization and on the front row, is going to do financial planning and analysis. And so he's working with Trey and his team and doing all decision supports for the whole organization. And so we're not going to just focus on the clinical mission, but the whole organization. And so we've got some work to do to be able to do the things that they want to, do some of the reporting that will be helpful to everybody, but that's what Sam's team will do. And then Jeff Grimsley and Mandy should be under here as well, but do the clinical side. And so they are no longer going to have to do the accounting. Joyce's team's doing all that, but they're going to be partners with our clinical leaders, just like Kelly DeSmuke, who's here too, is going to be partners with our academic and research leaders to help be your partner in strategy and managing day-to-day and managing your budget and helping just lead towards good financial decisions. Okay, and then the most fun topic of the day is what's the budget process look like? And so we have started meeting to talk about it. And so, we're only 4 months, almost 5 months into the fiscal year, but we do need to start planning for the 2025 budget. And so we've got some system challenges. We're going to limp along one more year with the current system that we have, and so we're trying to get that ready. But the more important difference is we want to partner with everyone across the organization in a little bit different way and be able to meet with you, work on strategy and kind of a glide path to what can we do to help you support your growth, your vision, and make sure it rolls up that we can meet those measurements that we talked about earlier. And so inevitably, if everybody puts in what you want and we add it all up, it's not going to work out. And so, because none of us can ever get everything we wanted, me included, it's just the reality that we're in today. But we do have to set priorities for the organization. And so we want to make sure that everything is weighed in appropriately and that we allocate things the way the organization intends. And so we'll spend a lot of time working with you to work through that, to make sure we're presenting that. And we're going to start that in that December, February timeframe. And so I know some of you, Kelly's got some things planned already, some with Dr. Rogers and Bidwell, but we'll start that then. And then the goal is to work through this where we'll enter it in, sum it up, work with you to make adjustments and be in a position in that May, June timeframe to submit it. The importance of that is we do have to get IHL approval of our budget before the end of the fiscal year. And so we do have to present and get approved. I think we'd like to show them in May and get final approval in June. So that's kind of the time frame and the plan. But we're happy to take if you got ideas on what we can do better, different, we'd love to hear them. And that's all I had, unless I'm happy to answer any questions. So, yes, Dr. Yeager.
So I have a question is, since most of the revenue comes from the clinical side, what would you say to those of us who are working in the trenches, in your view from the top? Are there a couple of things that you could say that you would wish that we in the trenches could do better to improve the health of the organization?
Oh, that's a good question. So my wish list. I'd say focus on documentation and understanding what that really does. And so it's very hard, you're busy, and the last thing you want to hear is how we need you to document more. But the documentation of the care we're providing in the hospital is what drives the coding of that care, which is what drives the reimbursement for that care. And so if you don't document your thought process and everything you're doing so that we know it, we may not capture some very important things that leads us to not be paid as much as we would otherwise. And then I would say get smart about the cost, the true cost of your care. And so I couldn't as an administrative type tell you what's the right thing to do clinically, but I can tell you there's a wide variation in cost on some of the choices you have. And so there are drugs, older drugs that are generic, newer drugs that are crazy expensive, supplies the same. And so I would say make sure you're smart about what the cost of those things are and make the best decision for your patient. I mean, if they absolutely need the most expensive, then we want to be in a position to be able to do that. But if there's not a reason, is there a more cost-effective way that does make sense? And the right status, if I could say that. And so one of the things that's very hard is payers today are paying, there's a nuance in status. So status is, am I an inpatient or an outpatient? And it would be really nice if we could say, if you spend the night in the hospital, you're an inpatient. But it doesn't work that way. And so there's a thing called observation now, where patients can effectively stay in our hospitals for several days and be an observation. An observation essentially pays us an outpatient rate. And so it's very important that we get the status right. And it's become a bigger and bigger issue as we go. And so we get a lot of takebacks because a patient will stay one night as an inpatient and the payer will say, oh, well, that could have been an outpatient. And they generally pay a lot less money on an outpatient. So status, that would be my third request. Okay. Anything else?
In that same vein, have y'all considered anything like, and maybe it already exists, like education for the clinicians on, appropriate documentation and coding and you know, or how can we be aware of the cost of things? I have no idea.
Yeah, coding, we do have some nurses that help do that, and that would be, I need Dr. Didion and Sharon to help me answer some of that probably. Cost, we can always do better, and so we do need to figure out ways that we can share that data, and that's a challenge everywhere, but I don't know of anything that we're doing, but I agree we need to figure out how we can.
Yeah, so that's the clinical documentation. For
Yes.
And we have that on the inpatient side. Where we struggle, to your point, is on the outpatient side because the volume is so big, but we are looking at ways we can optimize that and provide that.
Good question.
There could be something where the clinicians could get CME, you know, protected time, maybe for sessions. That would help them with, you know,
Okay.
a lot of appropriate coding and billing, and then hopefully in a way that would not increase note load.
Mhm.
You know, it's very important that if we're efficient with our time, our notes aren't getting too long. So just keeping that in mind.
Yeah, okay. Jeff, you gonna help me with that one? Maybe we can figure out a way. I mean, that's a good point, though. It's complicated. I mean, it is. So the more we can do, I think the better for sure. And we're not looking to code wrong. We're just looking for proper documentation, and so to make sure that we're paid. And it helps us on the infections, the quality side, if it's documented right, and it helps us on reimbursement generally too. So getting it right is what's important. Anything? Okay. Well, thank you guys for coming.